So Rich, you're in the world of melanoma, and you basically, chemotherapy has disappeared from your world, for the most part.
I use it very, very
Right.
rarely.
So you've got targeted therapy, and you've got IO therapy, and in some cases you have options to use both. You'll have a population of patients who are BRAF mutated, for which there is evidence for both types of therapy. To what extent, and even if you don't feel any burden to, if you feel somewhat protected by your status in institution, could you perceive a situation where a practitioner in the community in OCM might feel that their choice is that they can't just make a choice based on what they believe to be the better option, especially when the short-term data points are similar, but we have evidence that long-term data points may not be?
Yeah, so oh boy, I hope practitioners do not feel that pressure. I mean, I can say certainly at my institution and the other kind of folks in the academic melanoma space, there's constant debate as far as should you do targeted versus immunotherapy up front, given kind of the lack of long-term data, but no one feels a financial pressure to pick one versus another. Rather, we're definitely selecting therapies that we think are best for the patient. Now in the community, that I can't say. I don't know if there are different financial pressures there, but I would hope that's not the case.
It's got to be something that comes up at COA meetings.
Oh, absolutely. And actually, recently at our conference a couple weeks ago, we had a big review. In fact, Kavita led that in terms of the OCM 1.0, what we're working on the OCM 2.0. We actually had a group of practices in a closed door meeting talking about some of these issues in terms of the risk piece of it. And I have to tell you, I have not heard anybody say basically, oh, I'm pressured to use an inferior drug versus, in this case, we're talking about an IO drug, chemo versus an IO. I haven't heard that at all. But what's interesting is when you're making the decision now of going at risk, and you realize that this model, which again, I'm not unduly criticizing it, but basically has a basic problem in terms of price prediction. I have example of it after example right here of problems in that area. And now you're talking about going two-sided risk. You're talking about rolling the dice and putting your practice on the line. You just can't do that because you don't want to be in the situation as a physician where you've got to make that decision literally based on the fact your practice survival, I have to use an inferior drug. So what do? You drop out. You don't go two-sided risk.
Yeah, it's really challenging, especially if we're talking about combination immunotherapy, where if we do that, half of the patients will end up in the emergency room. A third of those are going to end up admitted for toxicity. So there are clearly added costs of doing some of these aggressive regimens that we certainly take into account from a patient perspective, the toxicities and managing that, but from a financial perspective.
You'd hope we could figure it out with IO, because if we have to start dealing with gene and cellular therapy, and we think IO is problematic in terms of the cost profile and that long-term perspective, it gets insane when we start thinking about therapies that could be curative and represent decades of life extension, depending on the population in the study. So it's pretty interesting. Susan, I always struggle from the patient advocacy perspective with how do you get shared decision-making with complexity of information of this nature?
That's right. So I'm glad you asked that, because there are two real positive opportunities with OCM. And one is the transparency in explaining to folks early and often what their financial impact of care is going to be. Simultaneously, there's a care plan that comes that is to be real transparent in what is my diagnosis, what does that even mean, and putting it into real words so that the real human beings understand what are we talking about. And so I think that those are, from a patient advocate perspective, when done right, patients are more clear on what's happening to them, which means that they ask better questions and engage much differently. If you do not understand what it means to be treatable but not curable, which is a language we use in oncology, you don't even know follow-up questions. What does that mean for me? You may hear that, and that might land very differently. If you don't understand what the Part D drugs are going to mean for you, right? And what that might mean when you're on a fixed income. You may make very different decisions based on just understanding that financial impact. And so the practices that have really transformed their culture are translating that clinical information into a language that patients can understand. And they're often doing that with the team members that are better at that. Your translators on the team, the advanced practice providers, the nurses and the social workers, specialized financial counselors who can then understand the clinical and the financial piece and be able to track patients over time and flag those folks when the cost of care is getting extraordinarily tough. Yeah.
So I'm curious about the perspective from the patient advocacy community regarding direct-to-consumer marketing. Is it an asset which brings them information that they need, or is it complicating because it kind of invades the provider-patient relationship by injecting another party into that conversation that's not really at the table, per se, at the time? I mean, they're there in that they're the manufacturer or the innovator of the drug. So how does the community weigh in on direct-to-consumer marketing?
Well, as you know, we're all watching TV and we see those really thrilling drugs that are still allowing us to play tennis. And so yes, obviously we do.
It's like the old joke, right? Like, he won't be able to play violin. How's it go again about the violin?
Yeah, I never played violin before, but now I can because of this drug.
Yeah. I blew that one. That would have been so good. All right.
But we know that folks are online and consulting Dr. Google every day. And so you have to, if you're in the oncology world, you have to be prepared that folks are reading things. That doesn't mean they're reading the right things or reading anything about them. And so I think that oncology practices and oncologists in particular are prepared during those initial consults to be able to answer questions from WebMD and to be able to level set of here's what you're looking at, which might be different than all of the people in your support group or on the discussion boards or whatever else has come into your inbox. Yeah.